Hello there, fans. Dr. Carlo Oger, board-certified emergency physician with DrER.TV. You are watching ED Exit Video Pro, the place for healthcare workers and healthcare enthusiasts education. Today, we're going to do this case. It's a healthy 35-year-old woman who presented with 3 weeks of fever. The patient had been evaluated for similar symptoms 2 weeks before and received a diagnosis of non-specific viral illness. Sadly, I have to admit, something we do. I mean, cold symptoms, have a fever, I don't feel well, they have a cough. It's a virus, right? It's not until patient experiences the symptoms too long or there are other symptoms associated with it where we're going to start thinking about other diseases. She reported persistent dry cough and dyspnea, which is shortness of breath during this time. She denied gastrointestinal, genitourinary, or gynecologic symptoms. She's a native of Haiti, living in Boston for 2 years. On physical examination, she was tachypnic. That means she was breathing fast. She was tachycardic. Her heart rate was fast. And she was febrile. So let me stop right there. This is a patient that because of those three things, this patient has SIRS. SIRS, Systemic Inflammatory Response Syndrome, by the fact that her respiratory rate is high, her heart rate is fast, and the fact that they have a fever. That means that we're going to trigger blood cultures, we're going to trigger a lactic acid level, we're going to do urine cultures, chest x-rays, we're going to do the works on this patient, okay? But she's not acute distress. Her room air oxygen saturation was 85%. Okay, right there. This patient's getting admitted. She ain't going home, okay? So even if you don't make the diagnosis in the ER, at least she's getting admitted. She'll probably have consultations with pulmonary doctors, infectious disease, people smarter than me in order to make a more definitive diagnosis. Also, she was on 4 liters of oxygen via nasal cannula. The patient's CBC and chemistry panels were within normal limits. That means her white count was not elevated, which is pretty impressive with the fact that she has a fever and hypoxia. So that's kind of odd. Her chest radiograph is in the next picture. So here's her x-ray. And remember, we've talked about grossly normal, grossly abnormal. This is a grossly abnormal x-ray. It's almost like somebody took the x-ray and just started doing a whole bunch of little dots. Well, smaller than that, but smaller than that. There you go. And did that to the x-ray, right? Now that I'm doing this, I'm going to erase it and see if you can see what I'm talking about. It's just got all this kind of like dots, like gray and white and little dots everywhere, right? The heart size seems appropriate. It doesn't seem enlarged. The costophrenic angles are good. They're sharp, so there's really no focal infiltrate. It's just this diffuse, spotty looking x-ray, right? All right, so let's talk about the diagnosis. This is miliary tuberculosis. The chest radiograph shows a faint diffuse homogeneous reticulonodular, so the nodules are those little dots we're talking about, reticulonodular markings, suggestive of miliary tuberculosis. On further investigation, the patient reported a history of a positive PPD, Purified Protein Derivate, PPD test. Result: induced sputum was positive for Mycobacterium tuberculosis by PCR, polymerase chain reaction, confirming the diagnosis. Miliary tuberculosis is a clinical condition that may manifest after hematogenous dissemination. That means that this is almost like a shower of little infections that settle into lungs. So all those little dots are little little pods of infection of Mycobacterium tuberculosis. So the bacteria is in little pods. This is growing. It classically presents with diffuse millet seed-like opacities uniformly distributed throughout both lung fields on a chest radiograph. Miliary tuberculosis is a condition that is rarely diagnosed in the United States. It should be suspected in patients with tuberculosis. Risk factors, let's talk about that. International travel or incarceration. Immune compromise as well. Who present with respiratory symptoms and a fever. Delays in diagnosis may result in severe morbidity and mortality because we're going to miss that diagnosis. This is a rare disease in the United States. Unless they have a history of travel or incarceration or immune deficiency, then we're not going to think about it until it's obvious, and by then they're going to be pretty developed, right? So there is hematogenous. That means the spread was actually through the blood. It was traveling in the blood, and it settled on all those little dots in the x-ray, resulting in multi-system organ failure. Swift provision of anti-tubercular medications is crucial. And yeah, that's it. So miliary tuberculosis, you get that shower of little pods of infection of Mycobacterium tuberculosis. It's a rare disease diagnosed in the United States, but we got to diagnose it early or else patients in trouble. Diagnosis can be made with induced sputum samples and cultures and PCR, polymerase chain reaction diagnostic test. So hey, I hope you liked this video. I hope you learned a little bit about the presentation of miliary tuberculosis and what it looks in an x-ray. I hope you're loving this series of education, and that you comment, that you share, that you ask me questions for future videos and presentations. We'll see you in our next video. Bye-bye.